Okay. Well, thank you for the invitation to speak to you today, especially in English. It gives me the chance to be a bit slack with language, and this way also you can't contradict me or take me into hostage for whatever I'll be saying that is probably stupid in my other language. So, I'll be speaking to you about today about the system as it's being set up in Quebec. It's a process, it's not finished. The law is still being discussed at the National Assembly in Quebec. And I'm going to talk to you about how it's going to work and what we can expect from a public health point of view in this regard. I'd like to acknowledge that I'm speaking on behalf of my institution, which is an institution that's an expert institution that gives advice to both the Ministry of Health and Social Services in Quebec and public health units across the province. There are 19 of them, I guess. And I have to say also that through the last 2 years, we've been involved quite heavily in that file. And a number of people and organizations, both within Canada and associative partners, and also both within Quebec and outside of Quebec, have been involved in these discussions, and we've worked with them. And I know that they know who they are, but I want to make sure that they know that we acknowledge their work and their efforts too. I just want to start before, I know we're going to dinner, so I just wanted to insert a few kind of funny things. I was interviewed by a journalist at this journal, which is, I don't know how to describe it. It's an economic journal or paper in the US, and they came up with that title, and it's not the type of title that we use at the Institut National de Santé Publique du Québec. But I think it sets the tone pretty much of what we aimed at when we started working on that file, and where we end up making most of our recommendations and taking most of our focus. And I'm going to get on to this like this. The reporter goes on to say that it's a pretty simple idea of suggesting that. It's indeed a pretty simple idea. In this complex file, I think sometimes we have to keep it simple on some level and then move on, because it's a complex issue. If we want to tackle everything at once, we'll maybe screw up everything. So we stuck to the idea of commercialization and the commercial promotion of cannabis in the future industry in Quebec. The other one I thought was pretty funny too was because I always wanted to test how many people spoke Finnish in this kind of rooms, and I'm not going to test it today. But basically, what the title said, I used Google Scholar because I had no idea what it was saying, and they said the title says something like, "Well, Canada is legalizing cannabis, which is the federal government, and Quebec is trying to mitigate harms." I never thought about it this way, and we need nuances in that. But I think on some level it says something, because what is indeed being done at the federal level is codifying, legalizing a for-profit industry which has already much resources. And what we're trying to do in Quebec is to take the profit notion out of it, or not completely out of it, but to situate it beyond or underneath the goals of public health and public safety. So I think I wanted to set this forth because it sets the tone in which we approach things in public health. So pretty simple. I'm going to say where we come from, but the point is I wanted to discuss a bit the system in Quebec and the questions the strengths and the questions we still have going on. In public health, we're not specialists in psychosis or depression or whatever, and we work at the population level. So we work on incidence and prevalence of diseases and other conditions like road traumas, and we take this as a whole. So sometimes it implies trade-offs between choices that we make. But the main point is the way we approach that is the best way to mitigate harms in that file from our point of view, was to reduce the global consumption level in Quebec. We know it's pretty high, according to world standards. We seem to have been going down in the last few years, and we want to keep it that way. Sometimes we say also that we want to reduce frequent and intense consumption, and sometimes people tell us that it's not the same thing. We agree, but at the same time, 20% of the consumption of cannabis, like alcohol or tobacco, is consumed by 80% of the consumption is done by 20% of the people. So global consumption is largely determined by a small subset of users, which consume a lot, and that's a big problem for public health. That's a big way to think about it in terms of public health. And of course, you've heard about tobacco smoking and combustion. Sometimes the products themselves are something that we would like to skew people away from, like the combustion part of it. Situations, we have to be careful into not getting people driving before or consuming before they drive and such things. And subgroups, I talked about 20% of the users consuming 80% of the substances. Well, those 20% of the users tend to be in the lower socioeconomic status that we have. And health inequalities are at the heart of public health, have been for a long time, and they still continue to be a big preoccupation for us. So when we started on this, there were lingering questions. How do we go about it? Do we oppose legalization in public health circles? And we did a bit of research on that, and there doesn't seem to be a link between legalization itself and the level of consumption and arms in populations. And the European Observatory study has looked at different patterns of consumption in Europe, and I've concluded that the penalty regime attached to cannabis does not change the patterns. So we went on and found other studies that confirmed that commercialization was also an option, an interest in terms of cannabis consumption, and therefore we continue. It kind of confirmed what we thought at first, because we have a long history in public health with alcohol and tobacco, and even if you look at recent files like opioid overdoses in Canada, I mean the part of commercial promotion in that is big, has been big in alcohol, tobacco, and medications, of course, like opioid has been a big concern too. The lessons we learned from alcohol and tobacco is that systems based on profit motives are generating more users. They're increasing the use of the existing users, and they also adopt practices that reduce costs, such as entrants like pesticides, growth hormones. They also have industrial strategies like horizontal integration or vertical integration that are harmful to public health because they generate more users. And also, the long history of tobacco with all the litigations has created a bunch of studies on behavior of the tobacco industry, but you could do as well with the alcohol industry. And when the resources are accumulated in these industries, they use this to promote consumption and and they become barriers to public health initiatives in many ways. We turn to Colorado because Colorado has seen the most studies at the population level, and I want to outline also that by this slide that mass commercialization of cannabis has started in 2010, 2009, 2010 in Colorado. And so I'm not going to discuss the legalization that went on in 2014, but I'm going to focus on this period of post-2009, 2010, and I'm going to show you the patterns of use and the harms that came with it. Just an aside, I showed you that the commercialization began in Colorado with the medical industry, and it seems to be the same thing in Canada that's happening. We see pushbacks from governments on different marketing strategies from cannabis companies these days. We see investments from companies in medical clinics to support the activities of doctors in specialty clinics. It's maybe a question for a bioethicist, if you will. But this, as you know, I'm closing this, but you know, it seems interesting that the patterns seems to be the same in terms of public policy and patterns of use and commercialization, both in Colorado and what's going on in Canada. What you see here, I'm going to go very fast, but and there should be lots of caveats, not thousands, but a few caveats, but data are the best that we got. The sources of the data is the national survey in the US, and it shows that indeed the number of users has accrued in post-2009, certainly quite significantly, probably around 30–35%. I don't have straight numbers in my head, but on top of that, within the group of declared users, the users declaring daily or near daily consumption past 2010 has increased significantly too. So more users consume more and declare more consumption. If you compare Colorado to the rest of the US, you have this difference that's pretty interesting. Put this into perspective also that the consumption of cannabis is not the psychoactive component of the plant. THC is the most known component of the plant, and this has been going up also in Colorado as elsewhere in the US. That's data from seized products from the police forces in the US. But the indications are that in the regulated normal industry in Colorado, that the concentration has not been going down. In fact, it might still be going up. In Canada, it's the same thing. We see products on the market of medical cannabis up to 30% of THC and lower than 1% of CBD. And CBD is a modulator of THC, and we see a constant reduction contrary to the augmentation in THC. So that's maybe not a surprise then that what we see happening in Colorado in terms of public health, that's hospital admissions, emergency admissions that you see on top. We have data from 2010. They've been going up. The blip that you see at the end is probably related to the regulation of edibles. Some rules have been set up in 2014 in Colorado, regulating the products themselves, the amount of THC that's allowed in the products themselves. But the hospital admissions, which is when you go beyond emergency, have been steadily going up. As I said, there are lots of caveats, and we could discuss all this in questions, but this is the best data that we got on Colorado. As well, the poison call centers have been going up steadily after 2010, probably again related to the edibles, the drop after 2014, as well as the deceased bodies in which we found THC from people killed in road injuries. And this is stopping in 2010, but it's been going up since then. All of this might be a coincidence. We don't have strong epidemiological studies and associations as you referred to, but these are the best guesses. I'll leave it to you as to interpret all of this as a coincidence or a occurrence that has no link. For my part, I think that it is linked in some way, and at the Institute we have based our recommendation and analysis on these types of analysis. So how it's going to work in Quebec, we're going to have a public entity that's called Société Québécoise de Distribution du Cannabis, which is a Quebec Society of Distribution of Cannabis, which is kind of the same idea of a public body buying and distributing this substance. As alcohol, we had this monopoly for a number of years. But in Quebec, the sole provider and sole buyer of cannabis is going to be the SQDC. It's going to be a purchase monopoly. So anybody that wants to sell cannabis in Quebec at least on the non-medical side, is going to have to sell to the company. The types of products, the SQDC is going to be able to decide on what type of products are released and concentration and things like this. We have suggested at the Institute that the limit in THC levels should be between 10 and 15, and there should be at least 1% of CBD in the products. But we don't know how it's going to end up. The decisions are still being made and discussed. Quality control, there's going to be a power to test the products at the SQDC. The SAQ, which is the parent or entity that is going to be responsible for SQDC, is going to use its existing laboratories or use other facilities or other expertise to test the products. The retailers are going to be, at first at least, we've heard that we're going to be exclusively public, and so part of the network of the SQDC. There were going to be 20 at first, at T1 of legalization, if you will, but we've heard public statements saying that if we needed 300, we would have 300 to the territory. We will have mail-in products, so it's going to be sold probably through Post Canada or another mail order system. The retailers in the law project that's before the National Assembly, there's a provision that says that we can have 5 pilot projects. I've put it under retailers. It's not limited to retailers, but the statements that we've heard said that many retailers were interested, and that was not ruled out by the government. And so we've expressed our views on that. We said that first it should be postponed, that we have pilot projects, and we said also that it should be limited to a not-for-profit sector, or more aptly named prevention and harm reduction bodies or organizations. If you want to complete the picture of the system, you can't rule out existing illegal distributors that are going to continue their business, at least for some of them, in the future. How it's going to work is that the SQDC is going to buy products from Health Canada's regulated or licensed producers, which are private and for-profit for the moment. There's nothing in the law, in the federal law, disallowing not-for-profit sectors or not-for-profit entrepreneurs to apply, but so far I don't think it's been the case. The personal production, in terms of personal production, or at least even in co-ops, is going to be outlawed in Quebec through fines. And the medical system is in place. I put it in commas because, of course, it's not a recognized product in the country. So it's kind of a strange place where the only way you can get access to medications now in Canada is through for-profit retailers that can't give you much advice on anything related to other medications and your conditions, right? So this is going to be the setup. We have some questions around this. Is this sustainable? The SAQ, the parent company of the SQDC, is a for-profit company, and it's been generating a lot of money for our government. There are pressures to generate more revenues through that. And there are a number of other caveats in the law projects, such as the pilot projects that we think are questioning the sustainability of the system in its own logic now, which is not-for-profit. The retailers, we still don't know what kinds of prevention and harm reduction practices are going to be set up, either in physical stores or online. It's been said that the vendors would have training in harm reduction and prevention, but we still don't know how they're going to train, what type of advice they're going to give. And if remaining questions that we have is that if the system veers towards a for-profit system eventually, are these provision going to go down as they have in liquor stores and as has been seen also in the lottery field in Quebec? Same thing a bit, if the not-for-profit or the pilot projects are for-profit entities, is this going to fragilize the not-for-profit logic or harm reduction and prevention logic? Well, evidence from the alcohol field in BC suggests that it has, and it generates more uses, generates higher intensity uses, and also it creates more harms in terms of violence and all kinds of harms that we can see in the alcohol field. Of course, regarding the illegal distributors, we still don't know how the resources are going to play out regarding these distributors. Is the mull, and another question is regarding the way Health Canada is relating time up. So I'm going to finish pretty soon. Is it good? Are the controls for pesticides, for example, good? We have questions around that. I can address them later if you have some questions. The constitutionality is in question of the total ban on personal production in Quebec. Is it applicable to totally ban home production, for example? Is it going to be a fair application? If it is applicable, is it going to be a fair application? And is it going to direct users to not-for-profit enterprises or eventually to a for-profit enterprise? In one case, it might be seen as a good thing. In the other case, maybe not. And of course, the medical system, we have said that it's an element that could fragilize our system, because I've alluded to marketing practices and strategies that the companies have now in the medical system. And we have outlined this as a risk, because we're going to end up maybe in a situation where our medical system is less regulated than our non-medical system. So it might direct users to other things. Thank you.